So to start us off this afternoon, we've got Dr Fraser Todd, who is the Senior Lecturer at the National Addiction Centre at the University of Otago. Fraser is a psychiatrist and addiction medicine specialist with a PhD completed on the topic of cannabis and mood disorders. He works as a consultant psychiatrist with the alcohol and drug coexisting substance use and mental health problem stream within the Youth Speciality Services Canterbury District Health Board as a senior clinical advisor for, I can't say that, Maori, and yeah, I'm not even going to try, sorry, as a senior clinical lecturer for the National Addiction Centre. So I will pass you over to Fraser, who can give you the correct pronunciation for some of those things as well.
Kia ora koutou. I have a clinical role and a lecturing role and a workforce development role, and the Te Pou Mataraki name, Māori name, is the workforce development role out of Wellington. I've got lots of bits of my job, but the bit that interests me most is the conceptual stuff, and I'm going to talk today from a conceptual frame. I'm not going to present data, I'm not going to mention citations too much. I just want to get some thinking out there about complexity. Complexity, complicated things, it's the rule in addiction services. 70%, that's the figure that from Simon Adam's research of the number of people in community alcohol and drug services, two in particular in New Zealand, who have a comorbid, non-substance related Axis 1 current mental health disorder. So everybody's complex if you look deep enough, but it's par for the course within alcohol and drug treatment settings. Having said that, Eagle this morning talked about how addiction treatment is up there with other chronic disorders. It's very, very similar in terms of its outcomes. One of the things, though, is it good enough? I think it's pretty good, but we should be striving for more. And if we just look at some of the rough figures around what our addiction treatment provides, less than 25% of people with alcohol and drug problems actually ever access treatment. That the size effects of our treatments, all of which are short-term, as Eagle mentioned, 6-month, 12-month, that's short-term treatment for a chronic condition, and the size effects of all of our interventions are either small or moderate, which is as good as diabetes and hypertension, or it's the same as about CBT for depression, but it's still not great. We haven't got really potent interventions. If we look at the long term, and we look at those few studies that are 20 to 30-year outcome studies, actually there's no difference really between people who have had treatment and people who haven't. Doesn't mean that treatment doesn't work, and my hunch is that in fact what's happening is that the people who go into treatment, because it's not randomised, those researchers, the people that go into treatment are the people that need treatment, and we're doing pretty well to get them up to the level that people who don't need treatment, but it's still sobering that over the long term, with long-term chronic conditions, treatment doesn't seem to make a big difference. So that's food for thought. There are still significant gaps between services, both structurally between services, conceptually with the way we think. So we're talking still about people with alcohol and drug disorders, or mental health disorders, or both, and that's siloed thinking. And then, of course, our outcomes as well tend to be substance use, quantity and frequency of substance use, or as a proxy, treatment completion. And Eagle's talk this morning pointed out the frailties of looking at treatment completion as an outcome, given that treatment's usually pretty short. So a lot of those problems are really around the way we think about addiction and substance use problems. And generally it's about the problem of applying complicated thinking to complex situations, and I'll go into that a wee bit. The key is that complicated is not the same as complex, and we often conflate the two. We think if there's lots of bits and it's hard to handle, it's complicated or it's complex. In current scientific thinking, complex is a very different beast. It's the nature of a certain system which is different from a complicated system. Most people, most natural systems, most systems with people in them are complex systems. They behave differently to complicated systems, and we need to manage them differently. Our traditional way of thinking is complicated thinking. This is you probably haven't had this over here in Australia, this is an ALEC public health play. It's not the drinking, it's how we're drinking, and so we kind of changed it to it's not the thinking, it's how we're thinking, and it probably doesn't translate at all. However, what I'm going to do then is kind of talk a wee bit about complexity. There's a huge body of research now on complexity science. It's really detailed and complicated. It requires advanced mathematical formulas. But there are simple principles that you can bring out and apply. I'm going to talk about those and about the problem you get when you apply complicated thinking to complex thinking, some of the principles of managing complexity, and then very, very quickly look at clinical strategies that we've built into our national guidelines for working with coexisting disorders. We call it CEP in New Zealand. So complexity, what is complexity? Well, I don't know much about cars, except they go fast if you put your foot down, and they tend to go where you want, and they run out of petrol all the time. I don't know if that's a common experience, it's just my lack of knowledge about cars. But if we think about a car engine, it's a complicated thing. There's lots of bits, but the relationship between all the parts is a chain reaction. So, for example, my basic understanding of how my car goes is if you put a bit of electricity into a spark plug, it'll cause a spark. And that spark in a piston, when you've got petrol in there, will make it go boom. And somehow that makes the wheels go round. And so the more electricity, the more spark, or the more petrol, the more boom. You know, it's a chain reaction. Spark, or electricity, spark, petrol, boom. Right? It's a chain reaction. If you change the parts, the thing will function differently. But the relationship between all of them is pretty set. Now imagine if your car, when you did that the electricity also made the window wipers go faster. And that actually changed the amount of petrol going into the piston, which switched the lights on. And the light switching on turned the steering wheel, which made the more petrol go into the piston, which affected the window wipers. And there's a close relationship, a bi-directional relationship, multi-directional relationship between all those parts. Your car is going to function quite differently. And this is a complex system, right? And the difference is the relationships, the nature of the relationships between the parts, and the outcome and performance of the system is much more dependent on the relationships rather than the bits. It's quite different from a complicated system. Is that kind of making sense? You get the difference? Yep. In those systems, complex systems have different properties. They're not what we call non-linear. If you increase the spark or the electricity going in a complicated system, the spark rate will increase and there'll be more booms and the car will go faster. If you change something in a non-linear system, the output is completely different. It's not one-to-one. It's not predictable. Your car might go slower or faster or turn left or run out of petrol or the lights might go on. So you have an unpredictable outcome. That all the parts are interrelated. And so if you look at the picture, top middle of birds, the position of the birds makes a pattern. But actually, the birds aren't going, we want to form this big Y-shaped pattern. It's one bird is positioning itself related to the next one, and that bird's positioning itself related to the next one, and so on. And so the pattern emerges. And you get self-organisation, so you get flocks of birds, like the one on the left, on my left. And you get patterns. And depending on the number of birds and the wind or whatever, the patterns will be different. But the system organises itself because of the individual's relationships into patterns, and it can adapt to conditions. So if it suddenly stops snowing, all those birds don't think, well, we're going to get out of the snow. Well, they might. I don't know if birds think or not. But what happens is, because of the nature of the relationships, just the flock of birds then adapts, and it'll go and sit on a tree branch and do something different. It'll adapt to the conditions. The thing is, because it's non-linear and there's lots of parts to it, the behaviour is unpredictable. You may know where to intervene. So if you've got a shotgun and fired it into that flock of birds, it's going to change. Right? But we don't know how it will change. We can't predict how it will change. It will change. Birds all might fly away singly, no more birds. You might kill them all, or they might form different patterns. We really don't know. And the second final key property is one of emergence. So if we look at a picture of a forest of trees and a little glen and leaves, right? That's got a certain nature. That wee ecosystem's got its own nature. If you take many of those ecosystems and put them together, they interact to create a forest, which has a definite pattern to it. That pattern isn't predicted by the trees and the leaves. You couldn't look at the trees and the leaves and go, this is the pattern we're going to get of this forest. It emerges. It has its own properties. You can go the other way. You can look at this forest and go, oh, well, we can work out how these leaves and trees might be organised. That's reductionist science, but you can't go the other way. That's the nature of emergent science. And the other key thing too is that it's scalable. So the details, each level of emergence may be different, but the principles are there at each level. So this is a fractal. The key point of a fractal, which you'll be aware of, is that the whorl shape, the big whorl shape, is made up of lots of almost identical little whorl shapes, which are made of lots of little identical smaller whorl shapes. So at each level of sophistication of emergence, you get similar, not identical, but similar patterns, similar principles. So when you get complex systems, and as I said, anything that involves lots of people is a complex system. It's going to be complex. Anything that's a natural system is going to be complex. When we apply traditional complicated thinking to it, we get problems. The first thing to point out is that complexity of a system is made up of a number of units. The more units, the more complex. Only one or two units, it won't be starting to behave complexly. The nature of the relationships, are they strong, are they weak, which ones are, which part relates to multiple other parts versus only one or two, and also the speed of change. So it's a cyclical thing. You go through a cycle, the birds fly up into a flock, and then they'll change into another flock, then another cycle, and the speed of change also influences the complexity. The problem we get when we think linearly about it, and even not, but the problem we get is our brains aren't often big enough to hold all the information we need to about a system. We get cognitive overload. Our patients get cognitive overload when we give them too much information. They don't take it all in. And the response to cognitive overload is often to narrow your focus. You focus down on what you know and what you can manage. It's very useful in many circumstances, but in others it's not. Because if you've got, say, a mental health system, and it's all a bit big for me to get my head around, I'm going to focus down on alcohol and drug. Right. And my colleague working in anxiety disorders might want to be thinking about the bigger picture, but they'll focus more on anxiety. And as that happens, let's go forward twice. As that happens, they get their own culture. They self-organise. My outcomes are about alcohol and drug treatment. They're about treatment completion. Most of the data I've got to collect is about treatment completion. It's focused on alcohol and drug. My colleagues is focused on anxiety. So we focus down, and eventually the culture of our services change. The way we practice and behave changes. We get disconnects and we get silos. It's a major cause of silos. What silos mean is you get more units, and so you get more complexity. So it goes round and round. One example I want to raise is, this is the New Zealand government structure, but if you look at health, our departments, health, justice, social development, behave quite differently. They've got different cultures, they've got different goals. One would expect, as a taxpayer, and I think most taxpayers would say, that we think the role of government should be about enhancing our social well-being. But none of the functionaries of the government have that as a goal. You know, education is about teaching. All of these have a role in terms of well-being and health. Right? Education, getting a good education, how you do at school, that has an outcome, that has an impact on your personal and therefore the social well-being. But education doesn't recognise it's got a health role because it's siloed. Right? And if we look at the disconnects in the system, then there's disconnects throughout the system. In New Zealand, it's probably similar here, but every government department is quite isolated. They've been struggling for years about how to bring things together. Mental health and physical health. Within mental health, addiction and mental health. Within addiction, NGOs and mainstream, there's disconnects throughout the system. And it's about the silos arising because of narrow focus, cognitive overload, those processes, applying complicated thinking. There are principles about how you manage complexity, and the general principles are, and you need to do all of these things, not one or two, and there's problems if you do one or two, because that's narrow focus, complicated thinking. Is first of all the big picture. If everyone shares the same big picture, you're going to get a commonality of outcome, commonality of purpose. Within health, you could argue, I would, that quality of life is the big picture. It's what we're aiming for. You could argue that across society it's quality of life. It's obvious to say that, we all know that. Problem we get is we just have to remember to think about it. In clinical practice, you know, I find, even knowing this, I find I am focused down on addiction treatment or mental health and addiction treatments or whatever. And I have to work really hard for a whole lot of reasons to see my key outcome with the people I work with as quality of life. The second way is to manage connections. So if those government departments had stronger interrelationships, different interrelationships, serving a common big picture, the silos would be much less. There's also conceptual connections between, we think of, when you do an assessment, for example, you might think of the alcohol and drug history, the mental health history, if you remember to do it. And interestingly, in New Zealand, despite lots and lots of education over 10 years and requirements for reporting, less than 50% of services still ask about both mental health and alcohol and drug. So those conceptual connections that you make. And then the other is vital behaviours. What are those vital behaviours that you can influence that will shift the system? So if we're talking about working with a person, what are those key vital behaviours that can shift the system? Now, I'd also argue that after years of practice, we get really, really good at sort of implicitly managing some of this, that we as clinicians tend to know where those vital behaviours are. And that's really good. What we don't know really is how to influence them, how they work, because it's unpredictable. A really good example of that, and I kind of think it's quite funny actually, is in the recent journal, July Journal of Addiction. There was the initial pilot studies of pay for performance released. And that was where 4 or 5 services in the UK were funded for the outcomes of their treatment. You do better treatment, you get more money, right? Potentially a really, really good idea. What you're doing is reinforcing in a complex system the outcomes you want. The problem is that the outcomes were that those services did worse, right? And that's a bit of a warning, because both New Zealand and Australia are at government level looking strongly at paper for performance. It's a potentially good idea, and it works well with complex thinking, except what they didn't do is they didn't look at the big picture. Right? So the funding was based on 1, treatment completion, and 2, did that person come back for more treatment within 12 months? And what they found is that actually fewer people completed treatment. Right? And so those services wouldn't have got extra money. And probably the reason was, they thought, that people kept their patients longer, because they didn't want them to come back within 12 months. And so they kept them longer, and the people get, oh, I'm doing okay now, I don't want to go through another 4 weeks of treatment, I'm off, see you later. And so that was an unpredictable effect of what they were trying to do. Right? It's an important lesson. The other thing is, because you get unpredictable effects, you've got to monitor things really closely. Right? You can't just go, all right, we're going to do this and we'll see what happens in a year. You need to look at it really closely, because it may be that you are getting these unpredictable results that are not the direction you want, and you need to change, because they're unpredictable. We can't say exactly what the intervention is going to do. If things are getting worse, you tweak them, you change them. Right? We kind of know this from clinical practice. A lot of this managing complexity is the same thing as we would call the art of clinical practice. You've got the science. The art, which falls between the gaps of the science, is often about our intuitive sense of how to manage the complexity. But the key message is you need to do all of those things. If you do what they did in the UK with paper performance and reward treatment completion as an outcome and forget your big picture, which surely is quality of life, right? And you forget that's a long-term chronic condition, and that people coming back to treatment within 12 months may actually be a good thing, if they need to, and doesn't indicate necessarily a lack of effectiveness of treatment for addiction, which is a long-term thing in most cases, then you may get good results. But they forgot or weren't aware of the need for the big picture, and weren't aware of the potential unpredictability, and so they got these funny results. Also with that, the close monitoring, you need mechanisms. The monitoring gives you feedback, and you need to be able to dampen the change or stimulate the change, feed forward or feedback. Feed forward, i.e. funding for performance, is a good idea as long as you do it within the context of all the rest of the system. So thinking about that, we in terms of our sort of national guidelines for working with coexisting problems, we've had various versions. The current one is 4 or 5 years old, and we've just updated it in terms of pulling out some of the things that were meant to be there but weren't recognised. People used to cherry pick the bits they wanted, and so we've kind of gone, actually, your big picture is the first thing. Until you can do the big picture, don't bother about the rest. And so the big picture is quality of life. And for example, if somebody starts using more drugs but has better quality of life, is that a good outcome or not? Well, you could see in some ways that it is. So how do we capture someone's quality of life? Well, 1, measuring outcome by rating quality of life, not treatment completion, not number of drinks. Those are useful, but adding in quality of life measures. I think down in Victoria, where I was in April, they're using Outcome Star, which does that kind of thing. That's really useful. It's not free, and so in New Zealand we wouldn't use that. We would use the HUQOL increasingly. Just the tip of the iceberg at the moment, but more and more services are using the HUQOL as an additional measure of outcome. Okay, there's a HUQOL validated in Australia. So it's a quick 100-question useful tool which measures, psychological, physical, environmental, social well-being. Just gives you a measure of how people are doing outside of just the alcohol and drug. Also identifying personal values, and many of you working in addiction will be aware of Bill Miller's personal values card sort exercise. Lovely exercise, but getting to know who is this person. Who are they? What is important to them? What are their values? What are their strengths? Right? We talk about strengths approaches. This is not new stuff. What is their identity? Hopes. What is well-being for them? What is the meaning in their life? What's their identity and niche? These things, you gather information on these things. People get the sense that you've captured them, and as a starting point, you've captured what's important. It's easy just to say those things. It's how you do it. And the concept around quality of life, or well-being, if you like, similar to recovery, but I guess we think that recovery is a response to having been unwell, and well-being is just this independent, neutral thing, regardless of whether you've been unwell or not. And also that recovery is a word owned by the consumer movement, and in the same way that, I don't know if this translates, but in New Zealand, I work with Māori quite a lot, but I would never tell Māori about what their culture was. It's not me to tell them, it's them. I wouldn't tell people in recovery what recovery was. So I'll use a similar term, well-being, but also well-being is differently defined, and so there's dimensions that have been identified in your rating scales and things you can capture in the way that we as clinicians would find useful. In terms of the importance of the big picture, just couple of very brief examples. One very, very articulate young woman I was working with had borderline personality disorder. It was really more of a developmental phase of post-trauma, as most adolescent borderline personality disorder is. She was getting treated with dialectic behaviour therapy. She disengaged from treatment. She'd been doing really, really well, and she disengaged from treatment before she completed it. And what she said was, I appreciate what I've learned, and that treatment has given me some helpful skills, but focusing all the time on my problems diminishes my personhood. And I just thought, geez, that is so articulate when she said that, and that's just made me think about personhood since then. But that diminishes my personhood, and that's more important to me than regulating my emotions. Right? So the treatment didn't acknowledge the big picture. Who's this person? What do they need? How do we validate this person? Right? We're giving really good treatment, but we were treating with DBT emotion dysregulation. We were treating her like a case of emotion dysregulation. Another young man, 35-year-old, chronic schizophrenia, a weekly cannabis user. The outpatient team was struggling to get him to reduce cannabis use, which is increasing his psychotic symptoms, and sort of asked me I was doing some work with him, so asked me to give him a hand. And actually what he said when you asked him was, I've finally found a group of friends who I get on well with. We meet up most Sundays. They all use cannabis when we meet, and if I don't feel I fit in. Having friends is more important to me than getting rid of the voices. Right? And that's the big picture for him, that actually the voices were not as important as having social connections. Very valid. Doesn't mean that you don't try and stop him using cannabis, you just think of other ways. How do we help him? Given that the social relationships are so important, how do we help him function socially with less cannabis, or improve his social skills or whatever so he doesn't need it, so then maybe he can reduce it. But it changes treatment to some extent. So that's the importance of the big picture. In terms of and this is often the problem when you go from big thinking to clinical practice, how do you do it in clinical practice? The values card sort's a really good exercise. There's a great VIA strengths out of positive psychology, 240 question, 30-minute computer-based tool for identifying character strengths. And it brings up things that people would not initially have said, but go when they see it, absolutely correct. I wouldn't have said it, but that's absolutely correct. It's one of my core strengths. These things take time. And part of our clinical development is to produce things that community workers can do in 5 minutes. Not as effective. But, for example, the values card sort, we've turned it into just a paper-based version, tick boxes, which you can give them to do as homework and pick up next time. And so values card sort exercise, 30, 40 minutes of sorting cards and talking is a wonderful exercise. Community mental health workers don't do it. They haven't got 30 minutes. They haven't bought their cards today. Giving a paper-based version out. the character strengths, 30, 40 minutes on a computer. Alison Uge Price at Canterbury University has developed a 72-question paper-based version, which is the same thing you can give out. Again, clinicians are using it because you just have to give it out and then spend 10 minutes talking about it next time, rather than 40 minutes and a computer. So making these things simpler. How do you want to identify somebody's state of well-being? What's well-being to you? It's different for everybody, but what is it for you? And that's a really hard question. Think about it. If I said, so what is well-being for you? Right. Unless you've thought about it before, it's really hard. Okay. There's a positive psychology exercise, Best Possible Selves. Now, that's designed basically to make you feel better about your future, but it's actually also a really good way of helping you identify well-being, and it's basically this. Imagine yourself after everything has gone as well as it possibly could. You've worked hard and succeeded at accomplishing all your life goals. Spend 10 minutes writing down what that would be like. People can do that. Similarly, what's the purpose of your life? Well, there's a fast-forward exercise. You're retiring from your job, or it's your 25th birthday, or you're leaving school and your headmaster's making a comment, adapting it for the people you're working with. But your friends, your parents are there, they're going to make a comment about you and how you've done and how's your life. What would you like them to say? And what you would like them to say after discussion is often something that captures meaning and purpose. So there are simple exercises like that you can use to actually take things into clinical practice, and they're all really quick. The next bit, connections and relationships. Again, very simply, depends on the system level, but shared big picture. If the government departments all thought our job is to enhance social well-being, right, and we do this through education or whatever, and they all talk to each other and work together on it, we'd have completely different outcomes. We wouldn't get these government silos. Similarly with services. If my job in AOD and my colleague's job in anxiety disorders or the inpatient unit was to improve quality of life, and we had good relationships and we communicated frequently, strong relationships, we wouldn't get these silos where I go, I can't treat your social phobia while you're still, I can't treat your drinking while you're still socially phobic because I can't get into the groups that we use. And my colleague's going, okay, we'll wait until you've stopped drinking before you treat your social phobia. We have good relationships, we'll work out ways of actually doing that, especially if our goal is to improve quality of life. Service level, same, share big picture, flexible service delivery so that you have the flexibility to go and engage with other people so that your boss, I don't know what it's like here, but in a lot of services in New Zealand, if you spend half an hour having a cup of tea with somebody in another service, you'd be told to get on with your work. Whereas in fact, actually that relationship building is the core of this. The Dutch did a really interesting thing a few years ago where they actually said 10% of all service funding is for building relationships. And it made a dramatic difference. But that was the first thing that the next government cut out when they wanted to try and save money. They didn't have the big picture. Clinical level, slightly different. And we're trying to make relationships between people, obviously, but also between factors and the vital behaviours that we talked about. And so you're making conceptual links between things. And the key on the clinical level is actually your frameworks and your structures you use, because what that does is it brings those different concepts together under a framework. And good evidence that expert practitioners, they know more. What they do, especially different from non-expert expert practitioners, is they make connections. Right? And they make connections because they've got really good, big frameworks to work by. In terms of those, one framework is a 4x4 grid that you're probably aware of for formulation, where you bring things together and you can start to make links because you're putting spiritual strengths alongside biological vulnerabilities. I really don't know how those two interact, but at least I've got to think about it, And I'll be thinking about things that I don't normally think about by doing that. So clinical leverage points, I think this is a really important thing. This is a breakdown of stuff done by Donella Meadows, who worked out the main ways of intervening in a system. But the most potent ways are the hardest to do. The easiest ways are the least potent. But there's 5 levels here. 1, in a service, structural elements. You can put on new services underneath it, new functions. Easy to do. Doesn't matter. You need to do lots of them to get a big change. Feedback and delays, if they're closely linked to your goals, and those goals are appropriate. So the paper performance, the treatment completion as an outcome, wasn't really very closely linked to the goals of treatment. which is actually to help people get better. System structure, so, silos, sort of connecting better. But two key ones, and one that's, I think, is quite easy: change your goals. What are the goals that you're working with your clients? What's the goal of your service? Is it to reduce the frequency of alcohol use? Is it to improve quality of life? And then the big one, paradigm change, paradigm shift, and that's hard to do. But a really good example of that, which we're all aware of, is harm reduction. Right? And harm reduction's made a big difference to how we deliver alcohol and drug treatment and treatment for people with alcohol and drug problems. It's made a big difference. And that was a major paradigm change from abstinence to harm reduction. So in general, you've got these ways of intervening, but the key is that complex systems behave differently. Then you need to think differently about them. The real key is the big picture. And a lot of talk, we know the big picture, but a lot of talk has been about alcohol and drug treatment. And we need to shift that into the context of alcohol and drug treatment to enhance quality of life. Right? And then those other strategies. So that's the end of my talk. Just on time. Thank you very much.